The Dartmouth Atlas has been a familiar part of the American health policy landscape since the mid-1990s. The Atlas monitors healthcare utilization and outcomes in 306 hospital referral regions across the United States. I'm Gil Welch, and I'm here to interview my boss for the past 2 decades, Jack Wennberg. And my goal is to communicate Jack's quest to explore the epidemiology of American medical care, how medical practice differs in different geographic regions. It's an intriguing story, one that starts in Vermont in the mid-1960s and is still relevant today as the Dartmouth Atlas continues to monitor what is actually happening to healthcare throughout the United States. Chapter 4, Going Nationwide. Our story here again starts with a president. This time it's William Jefferson Clinton, the 42nd President of the United States, but it's really less about the president and more about his wife, Hillary Rodham Clinton, who headed up the Task Force on National Health Care Reform from 1993 to 1994. Now, the early 1990s was a pretty heady time, pretty exciting time in health policy circles, and there's all the interest in the Clinton reform, and you decide to put together a nationwide atlas. Tell us a little bit about your motivation, political, scientific motivation behind the Dartmouth Atlas.
Yeah. Well, the political motivation, I think, was based on our general concept of neutrality. We want information to drive the debate. And unfortunately, the kind of information that we prefer, namely population-based data, has not been available across the country. Right. The practical reasons why this became important at this point in time was because of the decisions that seem to be about to be made to implement national health service, or put it this way, national health insurance.
Right.
And we wanted to make sure that people knew where the markets were, just like in Boston and New Haven and around Vermont, and here we've been doing these different markets.
I mean, what the local markets were.
Right, and how much resources were being used, how many beds per capita, how many doctors per capita, how many hospitalizations, how many nursing visits, how many this and that, so that people would have a sense of what the system was actually doing to the population at risk. But even more directly so, achieving the right actuarial price for the insurance premiums that were going to be offered under this program required that you have local knowledge and regional knowledge.
And accepted that some areas might be much more expensive than others because they were using a whole lot more medical care.
Because their per capita rates were higher, just like we've talked about earlier.
Yeah.
So, what in the absence of a national database, we suggested that maybe the Medicare database would serve the purposes of drawing attention to this, but also form the backbone for a monitoring system that would deal with national performance measures. After all, you might remember that the original Vermont study or work was done to create a population-based data system. That was our purpose.
Right.
So basically now we wanted to extend that same strategy to the nation, starting with hospital service areas, going to regions, and then finally to large geographic regions associated with political boundaries.
Well, let's look at the Atlas just again and review really what you're measuring. You're looking at 306 hospital referral regions here. And these are geographic units in which people living within these boundaries get the bulk of their health care. And I think you'll agree with this statement, is that the health care is fundamentally a local market.
Absolutely.
Absolutely, okay. And one of the findings, and to me the most powerful findings of the Atlas, is how the supply of hospital beds influences some admissions but not others. And let me just go over this graph with our viewers. This is the association between supply and utilization, and down on the x-axis is the supply of acute care hospital beds per 1,000 beneficiaries, and on the y-axis is hospital admissions per 1,000. Now I'm going to throw some dots up there, and each one of those dots represents one of those 306 hospital referral regions. Now I'll tell you about the diagnosis. It's hip fracture, and ask you, what did you see here?
Well, first of all, there's very little correlation between beds and hip fracture hospitalizations. And this makes a lot of medical sense.
Even to a nephrologist?
Even to a nephrologist or an orthopedic surgeon.
Okay.
To all of us.
All right, to all of us.
Including the epidemiologists.
Okay, yes. And please go ahead, I'm sorry.
And basically, you can break down the whole question about hospitalization into a series of 4 different kind of probability estimates. First is the illness rate itself. Secondly is the rate with which people who are sick go to the doctor. Next is of those that go to the doctor, who gets diagnosed, and finally who gets hospitalized. That determines ultimately the cause-specific hospitalization rate. So for hip fractures, we basically have only one variable that is likely to vary at all, and that's the incidence, because people who break their hips know it. Diagnosis is a big problem for them. They have to go see the doctor. Access is not a problem in Medicare. In fact, everywhere in the country, hip fractures. Decisions on whether it's broken or not are easy with just a simple X-ray, or even just an exam.
Right.
And everybody who gets a hip fracture gets
in the hospital because they can't walk.
Right. And this is the classic way we have understood healthcare to be.
Right.
It's driven by demand, by illness.
Right.
And not by practice style.
Oh. And here we see that the hip fracture doesn't vary, suggesting there's no difference to speak of in incidence. They're all admitted. They all have an obvious problem, and you'd call them a black ball.
Absolutely.
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 Okay. So
even though they're red balls.
Even though they're red, the next time I'll fix that. Here I'll put up one more diagnosis. Talk to me about this.
Well, congestive heart failure is what we now call a supply-sensitive condition, which means that the intensity with which patients are treated depends on local capacity. It depends on the doctor's supply. Visit rates are highly correlated with the number of physicians, and the hospitalization rate depends on the bed supply. And it's one of those gray balls.
And this is what this graph is showing you, that the more acute care beds, the more hospital admissions.
Absolutely.
Yeah.
Absolutely. And what the important point, I think, here is that we don't know, in fact, we don't have a lot of evidence why this is happening, but we do know that high-rate areas are not doing better in terms of outcomes.
And this is a very different diagnosis. This is not something you just see on an X-ray. There are people who are severely ill, short of breath, and there are people who are somewhere in between. And so there's a lot of physician discretion in this decision. And when you say it's gray balls, this is where people who have more space on the shelf put more in the hospital.
Absolutely. So you can see Boston up at the top and New Haven down towards the bottom. In this distribution.
So the Atlas was first published in 1996. What was the reaction to it when it hit the street?
Well, first of all, I have to fill in a little bit on that story. Namely, while we designed the project with the assumption that the new health reform instruments or organizations were going to be the primary customer, once the health reform went down the tubes, we basically had to look for a new customer. So we decided that we would essentially try to distribute this broadly across the country with the hope that somehow practice variations would begin to become better understood, and better health policy would evolve from the fact that we now had that data. So essentially we just decided to publish it. And we got help from the American Hospital Association at the very beginning. And they agreed, initially at least, to market it for us. Eventually, the reactions were not all that favorable, and we were also somewhat concerned about having a provider being so closely linked to the Atlas that we made a mutual agreement that we would seek complete independent funding, which is what's gone on ever since. But anyway, that's sort of what happened there.
And were some of the high rate areas a little bit upset with the
well, it's interesting. If you look at it over time, I'd say that the high rate areas basically ignored it until much later when the Obama health reform got on there. And our data began to seep into the policy arena, and the justification for a lot of the estimates that spending would be under control came from the fact that we believe that about 30% at least of spending is unnecessary just for supply-sensitive care. And of course there, at that moment, when the providers in the high-rate regions began to see what some of the effects might be on them, or to imagine, there was a lot of hostility and negative feedback.
Because it was recognized that the Dartmouth Atlas was the source of that
information. Right.
Yeah.
And there were efforts to attack the messenger, but we survived those pretty well.
How do you look back on the effort now? The effort to put out the Atlas? Is it?
Well, I think what I think is probably most interesting is every day we get a compilation of press releases around the country, and the Dartmouth Atlas, now is part of the general landscape.
Yeah.
Who's the guy that's?
You got to feel proud about.
Yeah. And there was a recent article in Time magazine which said the famed Dartmouth Atlas as use of justification for raising the "more is not better" question. So I think we're on target with raising the fundamental issues that we've tried to, and maybe we'll see some constructive solutions.
Well, the Dartmouth Atlas is an ongoing effort to monitor the utilization of medical care and the associated health care outcomes in the United States. It has become a fundamental resource for researchers, policymakers, and anyone who wants to know what is really happening in U.S. healthcare. Many people have been involved, Jack, but you got it going. Thanks for making it happen.
You're welcome.